ourselves. The past can be undone, but we carry on our back the burden time always reveals. In the lonely light of morning, in the wound that would not heal, it's the bitter taste of losing everything that I've held so dear. I've fallen, I've sunk so low, I've messed up better, I should know. So don't come round here and tell me I told you so. Heaven bent to take my hand, I've nowhere left to turn. I'm lost to those I thought were friends, to everyone I know. Oh, they turn their heads embarrassed, pretend that they don't see that it's one misstep, one slip before you know it. And there doesn't seem a way to be redeemed. Though I've tried, fallen, I've sunk so low, I've messed up better, I should know. So don't come round here and tell me I told you so. I've messed up better, I should know.
Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920 WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Pamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you and mail your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York 12402. For more information or to donate online, visit our website at mykcr.org. And good morning, this is Dan Gatis, and thank you for tuning in for a Medical Monday, and thank you for being with us in this morning. 7 to 9 a.m. we'll be with you, and Monday, April 12th is today, and 45 degrees is the temperature right now. Considerably cloudy today with occasional rain showers, a high around 50. 50% chance of rain tonight, 40% chance of showers early and cloudy overnight, a low of 38. Tuesday, partly sunny, partly cloudy, a high of 64. And Tuesday night, generally fair, a low of 41. And Wednesday, sun in the morning with cloudiness increasing in the afternoon. Wednesday night, 70% chance of showers early, becoming steady rain late, and it's a low of 43 on Wednesday night. We'll be right back.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5. Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Thank you for being with us here at KCR, Kingston Community Radio. 331-9255 is our call-in number. 331-9255.
Everyone is talking about healthcare these days. America spends twice that of other developed countries on our healthcare system, yet our health ranks near the bottom. How can we stop spending so much and getting so little? Shifting to a system based on primary care can help fix the problem. Patients with a primary care doctor live longer, healthier lives and are less likely to suffer from cancer, heart disease, or stroke. Primary care that is comprehensive and coordinated also saves money. Patients who have a primary care doctor spend 30% less on health care than patients who don't. States with a high number of primary care doctors have lower health care costs and higher quality care. Primary care can help make America healthy again. To learn more about the benefits of primary care, visit www.healthisprimary.org. This message is brought to you by America's Family Physicians.
Hi, I'm Paula Strang, and I support Kingston Community Radio, and so should you.
Thank you for being with us here at KCR, Kingston Community Radio, on this Monday, April 12th for Medical Monday. And your call-in number, to call in to us is 331-9255. And we are here weekdays, 7 to 9 a.m. on WGHQ AM 920, 92.5 FM. And today is Medical Monday with Dr. Eric Stamberg and our guest. Good morning.
Good morning. Welcome to this morning show. I'll be here from 7 a.m., which is now, to 9 a.m. And we're going to talk about some various medical topics. Robin Baker will be joining us. And I also have a guest in the studio. This is a studio, I guess. A guest in the studio named Molly Goodman. She is a third-year medical student at Toro Medical College, which is in Middletown. And she was a surprise addition to our practice last week. She was looking for a rotation. Sometimes the experience of a third-year medical student, you're a little bit of a nomad, like, where am I going next? Where am I going next? So we were able to make room for her. And I think we had a good week. And I think she's a really fine student. But that's really, the camera's a lot closer than it used to be, Dan.
Well, she knows how to, I have to, because I got to get I got to get Molly in there.
Oh, of course.
Yeah, right?
Of
Okay.
course.
Yeah. And what was I going to say? Oh, my heavens. She negotiated this building perfectly.
Yes, she did.
Bang, she was here. She preceded you.
That's right. She's not the first student that I have tell to come to the show, and then they go, I don't know where I am. And then I come in like 3 minutes later. It's happened before. Anyway, so we're going to talk about various medical topics, and we usually start the show with kind of like the more of the actual medical stuff, and then as the morning goes on, we usually talk about the wonderful business of healthcare, and at some point do a COVID update as well. There was many times where we did COVID almost the whole show, and then so the fact that we moved it towards the end part of the show, it should not convey that it's not a concern of ours anymore. I thought we would talk about blood, because Molly knows that I struggle with doing what's called evidence-based care. What's really been recommended, proven to be efficient. A lot of times, as part of routine care, we'll do a CBC. CBC stands for a complete blood count, and there's no real evidence behind that. Matter of fact, Medicare, for example, doesn't cover a CBC just for the heck of it. They cover cholesterol levels with certain criteria. They'll cover a diabetes check with certain criteria, but they won't necessarily cover a CBC. If you have a diagnosis, it's usually covered. If you have high blood pressure, it's covered. If you have any heart problems, any lung problems. Anyway, so it's a common thing, though, for physicians and healthcare providers, such as myself, and as Molly will be in the future, to do a CBC. And why? And what are we looking for? Well, I was thinking about this, and I was also thinking about how amazing blood is. Blood is made in, where does I don't want to put Molly on the spot, but she really has been batting 100% with all the questions I've been giving her. Blood is made where? Which part of the body?
It's in the bones.
The bone marrow. I was thinking about this. It's almost like God or nature, whoever you want to believe in, or a little bit of both, said, all right, we need to make this blood. Is there any part of the body we're not using it? And they're like, yes, the middle of the bone marrow. It's just, to me, such an amazing concept that kind of almost like this storage, this warehouse that wasn't being used is where the blood wound up being made.
Is it the same for all vertebrates?
For all vertebrates?
Yeah,
I don't know.
For all vertebrates, like for instance, of course, it's probably true with mammals.
I think I really can't comment on that. I don't know, to be honest.
Okay.
We use a veterinarian or a biologist or somebody to give us an answer for that. I don't know about alligators where they make their bone.
Their
So I guess
blood, right.
probably.
Yeah.
And it's a little more complicated than that, but bone marrow is where, and generally there's three major lines of your blood cells, right? You got the white blood cells, the red blood cells, and the platelets. So, it's very common for a patient to get a call, and the call is, oh, your red blood cells are a little low, your platelets are a little high. What does that mean to patients? So let's talk about the white blood cells first. This is most helpful usually when we're evaluating some sort of illness, because the white blood cells generally are where the cells that are helping us fight infection. So if someone is acutely ill with something, they will be frequently elevated. However, certain illnesses will actually make the white count go down. Have you right? I had a. We're starting to see Lyme disease this time of year, and anaplasmosis and what's the other one called? But there's the anaplasmosis. That's the one too. Anyway, we're starting to see. So those illnesses frequently will actually lower the white blood cell count, and also viruses will lower the white blood cell count. Every now and then I'll do a CBC as part of routine care, understanding it's not evidence based. At some point I say, I get it. The evidence is important, but every now and then I say I still want to do it because I think it's best for my patients. And anecdotally, I have things have been picked up. So every now and then we'll get a white count that comes back high. I mean, it can be very high. Normal is about 10 or less, maybe 12 or less. It depends on the lab and where they come back. So sometimes it comes back like 15 or 16, and the person's otherwise fine. So that's kind of the call the patient gets. Hey, your white count's a little high. What does that mean? I don't know. I usually, if the person's otherwise well, and maybe I recently saw the patient in the office, did an exam, I say, whatever. We'll recheck it in a month, in 2 months, whatever. You're otherwise fine. Maybe you're getting over an illness. Maybe it's just a normal fluctuation. People with other chronic illnesses might have white counts that are a little bit high. People with things like respiratory illnesses, always some degree of inflammation going on. And every now and then we'll get one that's really high, 50, 60, even 100. And what would that possibly be indicative of?
Like a leukemia.
Like a leukemia.
Yeah.
Yeah, those are, that's a bad word, right? There's something called CLL, which stands for, and you can correct me if I'm wrong, chronic lymphocytic leukemia. This is kind of like a smoldering leukemia. It's the patients with this will have a CBC done, and it's quite high, 50, 60, and really people can live with this condition for a while. When I diagnose this condition, and it's a pretty easy diagnosis when it's made. If the patient's otherwise kind of well, and I did a CBC, that count comes back significantly elevated, 50, 60, and then you can break down the white cells into the type of cells. Are they lymphocytes or neutrophils? I don't want to get too technical out there, but Molly knows what I'm talking about. But if they're predominantly these cells called lymphocytes, the diagnosis is almost always CLL or chronic lymphocytic leukemia. It's more common as people get older. And I refer the patient to a hematologist, but a lot of times the treatment's just observation. All right, and this is Molly. Anyway, So you go to, do hematologists treat that? Sometimes they do. What do they do? What do they give? Are there any medications to bring the white cell count down, or they just observe it? I've seen a little bit of both, to be honest with you.
I think if it's not too bad, you just observe it until you think that it's getting worse, and then you take action.
Once you get closer to the mic.
Oh. Yeah, I think that for a long time you just observe it until you think that it's getting worse and you need to take action. But
right. So we're talking about white blood cells. Anyway, and then, yes, there are some other types of leukemia that are really quite alarming, unfortunately. The lymphocytic, the CLL that we're talking about, eventually does kind of activate and can be, but can be at that point even terminal, unfortunately. But it has really, that could be 10 years, for a while, a person can have this condition. It's where they have just kind of excessive white blood cells that can be picked up on just a routine CBC. And the other leukemias, right? There's kind of 4 major types, right? And then we play a little alphabet soup here. There's CLL, CML, ALL, AML, and the C stands for chronic and A stands for acute. But to keep it quite simple, the CLL is a diagnosis that you can live with for a while. Unfortunately, the other 3 are quite serious. What's the one that kids get? Is it, ALL?
Yeah, I think it is, yeah.
Childhood leukemia is actually a very good success story in medicine. You know, I remember a playmate when I was growing up. We had a boy who got sick with leukemia and passed away. You know, that's a boy who would have survived. So it really is a success story. We don't always remember our success stories in medicine.
You guys are focused on the illness a lot.
Right, and
I'm kidding.
Oh, you I don't. Okay. By the way, we're up close with the camera here. I had my makeup done in the green room.
No, I was commenting because you always talk about how the wellness visit has been like touted as being like the new wave, as if you guys haven't always been promoting wellness this whole time.
Right.
I
talk about like some people will criticize a physician like myself for focusing on illness and not wellness, and I say that's really not true. We've been focusing on wellness for some time. I don't know if we should say anything else about the white count, except that things could be a little elevated. Doesn't always mean something is wrong. I find people with respiratory problems like COPD and asthma, they can frequently have a slightly elevated white blood cell count. And remember, all these things, these normal ranges are what we call the upside down U-shaped curve. Here, like this. So even though normal's kind of up here, you always have people at the extremes that still are kind of normal for them, even though if you just look at the blood work, it might be a little abnormal.
You're doing like an upside down horseshoe shape.
Okay. We call it the U-shaped curve, but she's right. The horseshoe shape is probably a better image.
Right. With the points pointing down.
Yes.
And so either side is...
you have the tails.
Right.
And that's like, they do... the med school, traditional med school used to grade people on a curve like that. So, you have everyone really kind of clustered together. You still have people here that might get a very good grade or a very poor grade, unfortunately. All right, so let's talk about the red cells. All right? So red cells are known as, what's the other term for them?
Erythrocytes?
Yes. So what's that mean? This gets to a very big topic of anemia. You know, what anemia means you don't have, anemia basically means that your hemoglobin is low. Sometimes we use the term hematocrit. It's just another way to assess hemoglobin. Sometimes they're both low. And why? Well, when we do the regular blood count, we do look at some other features that can give us an idea if the red blood cells are big or small. Are they, a little bit of both? And there's some common causes of low hemoglobin and this can be something that really needs to be paid attention to. I always say to patients, and students and residents, I say the abnormality's got to be explained in some way, or at least a plan to address them. But a lot of people are told they're iron deficient. Have you been told that, Robin?
Yeah.
Yes. And whenever I have a patient who's iron deficient, and you get a pretty good clue without getting too technical, just looking at the lab results, you got to say why. Why are they iron deficient? And it comes kind of quite simple. Molly can help me with this. Either you're not ingesting enough iron, or you're losing iron.
You're bleeding somewhere.
So some people, generally, some people can be strict vegetarians and strict vegans, and maybe they're not getting enough iron in their diet and they should be on some sort of supplement. But for most people who eat animal products in some way, shape, or form, there should be enough iron coming in. You agree with that?
Mm-hmm. Yeah.
All right. So, unfortunately, whenever I diagnose iron deficiency, the at least in the back of my head, and I hate to scare patients, but the C word has to be considered. And that's why I wanted to bring this up, because I want people to understand how important it is to take this seriously. And what would be the cancer that you would kind of worry about with someone who's anemic? Hey. If you don't know, I don't want to be. This is really unfair to you.
That's okay.
What I'm looking at is colon cancer. Colon cancer very frequently will manifest as just iron deficiency anemia, and women are frequently anemic. They are anemic for menstrual cycles, pregnant. It's a very common story where a woman has 2 or 3 children. Each pregnancy, she's lost some blood. She never quite gets it back, and then there's another pregnancy, and then and also women who have kind of excessive bleeding. For various reasons, can become anemic, and that also is something that has to be taken seriously. Molly knows that I really don't do much GYN care in my practice anymore. Because I have a wonderful OBGYN department right on the other side of the door I share an office with. But part of my physical or review sometimes is I'll ask. And Molly's heard me say, kind of, if I have a woman in for a wellness visit, I'll talk about. Typically you don't need a pap smear after 65, whatever. But I usually try to ask a question, or you can't ignore anything. You can't ignore any bleeding, any spotting, any discharge. So any bleeding after menopause has to be explained, and because if it's not explained, unfortunately that can be indicative of uterine cancer most typically. It could simply just be menopausal, but really any bleeding after menopause has to be taken serious. Younger women will just kind of have irregular cycles, and they're heavy, and they can become anemic. And you don't necessarily, other than routine stuff, it's usually just a problem of regulating the cycles and making sure there's enough iron in the diet. Then you have this category of perimenopause, around menopause, women 40 to 50. This is almost the hardest of all, because the younger ones, you probably don't have to work up too aggressively for something serious like cancer. The ones who are postmenopausal, we've already said you really should. Then you got the ones that are kind of in the middle. Anyway, well, maybe we'll leave the rest of that discussion to another time maybe we can get a gynecologist on. But the take-home message is that any increase in your bleeding, menstrual bleeding, should be taken serious. If the flow is heavy, if it's happening more often, if it's lasting more days, if you're passing clots, could all needs to be kind of addressed. And I've had patients in my practice where they said, I had some spotting, and I said, okay, set them up with one of the gynecologists in the other room, and a few of them unfortunately did have the diagnosis of uterine cancer, and they're doing fine. Anyway, so back to colon cancer. So iron deficiency anemia, unfortunately, can be a sign of colon cancer. So that's kind of one of the reasons I do it, although that's not really an evidence-based screening tool. The screening tool for colon cancer is either, and we've talked about this in other shows, a colonoscopy, or now there's kind of substitutes for colonoscopy. The Cologuard is something that's all over television. And then there's a third kind of pseudo-Cologuard called the FIT, which is fecal immunochemical.
You can do it.
Fecal immunochemical test. So you can't call it a FIT test because you're basically calling it a test. The T already stands for test, so you just call it a FIT. Anyway, these things are okay substitutes for a patient having a colonoscopy. Molly will hear me kind of complain about whether or not it's covered. Some insurance, Medicare plans and Medicare will cover the Cologuard, but for other insurance, it's a little hit and miss. And that can be frustrating.
We do it a lot at our office.
Cologuard?
Well, people would prefer usually to do a test than to go and have their colonoscopy, although when we had the gastroenterologist on the show, he said there's no test that can show me what I can see if a patient has a colonoscopy. So yeah, I had mine. Wasn't a big deal, right? First
well, it's, a colonoscopy is you got to do a prep. You got to take a day off from work. You got to have someone drive you and bring you home. It's, I do feel, and my GI colleagues might disagree with me in this, but I think as time goes on, the Cologuard will become more of the standard. But and we had Dr. Rosenzweig on, who said they set the bar of sensitivity for the Cologuard very low. In other words, it's designed to pick up a lot, and as a result, a lot of times the test is falsely positive, which is okay. I mean, but some patients, They don't want the colonoscopy. We get the Cologuard. It's positive, so then they have to go have the colonoscopy. And I don't think I've had any who don't have anything wrong with them. A lot of times they do have polyps, for example. So and in one case I can remember just off the top of my head, it was a rather large polyp. So it was very good at this and precancerous one. So one of those polyps that's very close to cancer, but not quite there yet. So anyway, part of the importance of a CBC and taking iron deficiency seriously. A lot of times patients are told, hey, just take iron. I think that's not really the right advice. I mean, yes, maybe a woman who's having some menstrual problems and is having a hard time keeping up with iron stores, but generally you want to find out why they're deficient and fix that problem. Doctors, unfortunately, have said, okay, take iron, and meanwhile, maybe missed a case of colon cancer and with an outcome that has been good. There's some other anemias. I don't want to put Molly on the spot, but you're welcome to chime in. But I check B12 levels a lot. B12 it's so complicated. It's actually, how it's metabolized. You got to ingest it. It meets this thing in the stomach. It binds it, and then it travels down to the end of the colon, which is called the ileum, and it gets absorbed from there. It's a very complicated process. So a lot can go wrong in that process. Again, it could be dietary, although it's unusual. You have to really be a strict vegan or vegetarian to not be getting enough B12. And when we talk about B12, we usually talk about folic acid as well. They kind of go hand in hand. And these anemias can show, they show up, the red blood cells are big rather than small. With iron deficiency, you're anemic and the cells are small. And with B12 or folic acid deficiency, you're anemic, but the cells are big. But a lot of times people have low B12 and they're not really anemic, at least not yet. But that always has to be answered as well. You can have a problem in the stomach, unfortunately, that can be linked to inflammation and even cancer. I mentioned this thing that the stomach makes. So if the stomach's not making it, there's something wrong. So sometimes when I diagnose with B12, I run some other tests, but I do also refer the patient to a gastroenterologist to have an upper endoscopy. Should I explain what an endoscopy is?
Yes.
It's a tube with a camera. So we use the term usually a colonoscopy is really a type of endoscopy. Sometimes it'll be referred to as a lower endoscopy. So an upper endoscopy is where you basically go down to the throat and you look at the esophagus, look at the stomach, and you can also look at the beginning of the small intestine, which is called the duodenum. Anyway, so B12. B12 comes up a lot because other than anemia, it can also cause it's linked to dementia, for example, and I just find that it can make you what's that phrase? All work and no play makes you a dull boy. Where's that from?
The Shining.
I think it's Mark Twain.
Mark Twain?
I think.
But it was in The Shining, too.
That's just a little memory. Yeah, of course it was used in The Shining. But,
man.
I think it's Mark Twain.
Okay, so I think low B12 makes you a dull boy or a dull girl. It just kind of affects your sharpness and your cognition, and there's a lot of talk about that. Anyway, so what else should we mention?
Do you recommend people get B12 shots?
A
lot.
Well, the evidence really shows that that's not necessary in many cases. That person can just take some B12 supplements, kind of just flood the gates a little bit more. And there are also sublingual forms of B12. The theory is that it gets absorbed through your gum,
right?
And then it goes right into your bloodstream. I've heard some disagreements about whether or not that's actually happening or not, but many patients I just put on B12. Oral, but if that does not succeed, yes, B12 shots. And the frequency of B12 shots is controversial. I don't think you really need monthly B12 shots in most cases, but traditionally that's what has been done. That's a lot of B12. Sometimes I just do them every 3 months, and you just follow some levels. A couple other types of anemia that are worth mentioning. One is. This is a common diagnosis. It's called anemia of chronic disease, right? And we see this a lot. This is, in the simplest terms, this is just kind of you're sick with something else. And for reasons that I'm not sure we even understand, the body responds by making fewer red blood cells. It could be it's common with kidney problems, and that there is an explanation for that. Something called erythropoietin, and without getting too technical, sometimes people with kidney problems have to receive shots to keep the red blood cells up.
Diabetics?
What?
Diabetics?
Maybe. I usually see it more with, like we mentioned, COPD, CHF, just kind of a chronic inflammation scenario will cause anemia of chronic disease. And it can be severe. Some people have to, in the hospital setting, they come in, that hemoglobin's quite low and sometimes need blood. And finally, there's these things called, what if we were maybe Italian family, got 1 minute to our break, Italian family or a Greek family or African family or Asian family, certain types of anemia. You know what those are? Thalassemias. So these are, just without simplest terms. A lot of times, you can look just at a CBC and make the diagnosis. Someone is mildly anemic. They have small cells, but they have a lot of cells. And a lot of times this is just something people live with. It can be an issue with the families. If two parents have it, they can then have a kid with a major blood problem. I had a case of that in my practice about 15 years ago. The kid had to get, transfusions, and there was hope to do a bone marrow transplant, which, this is in the realm of pediatric hematology. I don't know how they moved away, but I hope the child did well. But that was very upsetting diagnosis. But it's the history's all. Oh, let's go to our break. All right.
Thank you, Dr. Eric Stamberg, Robin Baker, and Molly Goodman. Thank you so much for being with us this morning. And it is 7:30 a.m., and you are with us here at Kingston Community Radio, AM 920 and 92.5 FM. My name is Dan Gatis, and it is Monday, April 12th, 45 degrees here in Uptown Kingston. And James Howells, collection of proverbs from 1659, gave us, all work and no play makes Jack a dull boy. All play and no work makes Jack a mere toy. And there you have it. It's from 1659, and I misquoted Mark Twain. The weather and forecast for Kingston and the surrounding areas: considerably cloudy with occasional rain showers, a high around 50. 50% chance of rain today as well. And tonight, 40% chance of showers early, cloudy overnight, a low of 38. Tuesday, partly sunny, partly cloudy, a high of 64. Tuesday night, generally fair, a low of 41. And Wednesday, sunny in the morning with cloudiness increasing in the afternoon. And Wednesday night, 70% chance of showers early, becoming steady rain late on Wednesday night for a low of 43 also. We'll be right back.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5. Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
My Shiro always goes the extra mile, stretches every dollar, puts others first. But now it's your time, Mom. Get free tips to help boost your retirement savings now at aceyourretirement.org/Shiro.
Brought to you by AARP and the Ad Council. You care for the house, the kids, and our future. A Shiro's day is never done. So let's start saving a little more now. Get free tips to help boost your retirement savings. Visit aceyourretirement.org/Shiro. Brought to you by AARP and the Ad Council.
Don't. Just don't. If you see a low-hanging or downed wire, don't touch it. Don't move it. Don't go near it. Don't drive over it. It may be a power line carrying an electric current strong enough to kill. But here's what to do. Stay at least 30 feet away and call 911. Central Hudson will take care of the problem. If you come close to a wire, shuffle away with small steps. and watch your step. Wires may be hidden in fallen tree limbs or near water. Your safety matters.
Hi, this is Scott Harrington from Hurley, and I support Kingston Community Radio because the people need a place to have their voice heard, and it's lost in corporate radio, so please keep listening and supporting our station.
You're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. It's 45 degrees on this Monday, April 12th, and Kingston Community Radio is talk radio, and we welcome your call-ins. 331-9255. You got a hunch, you got an idea, you got a thought, you got a question? Call in 331-9255. And this upcoming portion of Kingston Community Radio is brought to you by Central Hudson. Now let's get back to the on-air studio with Dr. Eric Stamberg, Robin Baker, and Molly Goodman. Welcome back.
All right.
Goodman is such a good name for a doctor.
It is a good name.
My first doctor was Dr. Good.
Dr.
There you
Good.
go.
There
Yeah.
you go.
I know there's some funny names of doctors, but I don't want. They might be listening, so I don't want to bring them up. Well, have we drained the blood out of this topic, or?
I don't know. Did you talk about platelets?
Wow, you are paying attention.
I was, yeah.
Okay, so we talked about red blood cells. The take home was to really, if you're told you're anemic, you really got to know why and what to do about it. And the C word is in the list of possibilities. So a look has to be, if you're of a certain age, you have to have you really should have a colonoscopy. What is that age, right? I mean, there's no clear answer to that. We know people at 50 get screened. The evidence is actually bringing that down to 45. And I really think, but what if someone's 38, and they're anemic, and it's a woman, they say, I'm nothing wrong with my menstrual cycles, I go to my gynecologist, should that person get a colonoscopy? The answer is, I don't know. I guess I would probably refer that patient, at least for an opinion of a gastroenterologist to look, because unfortunately there are cases of colon cancer. And by the way, stomach cancer can also manifest, and ulcers as bleeding too. So I guess you have to just make sure it's not from the GI tract in general.
Molly was just mentioning on our break that when she was on her GI rotation, if you just share maybe with the audience, what the GI doctor was sharing with you.
Mm-hmm. Yeah, so he was saying that about 25% of the time when he does a colonoscopy, he finds at least one precancerous polyp in a patient. So it kind of just reminds everybody how important
that's a high number, 1 out of 4.
Yeah, so that's 1 out of 4 people where that polyp could eventually down the road turn into cancer. But if you get a colonoscopy, it gets taken away and you're all good.
Right. People are resistant to that. It's we talked about reasons why. Sometimes patients will say to me, well, I don't want to know. I'm like, well, you don't want to die from colon cancer. It's bad. There's no other way to describe it. You say, well, this isn't a Kenny Rogers song where you're going to die in your sleep. I mean, this is a rough go. Cancer in general. So when people say they don't want to know, that's pretty ill-informed.
Gotcha.
Platelets. So platelets are, what do they do primarily, Molly?
Well, they usually help with blood clotting.
Clotting, yes. And she gave a visual with the clotting. You see that? Right. So we need platelets to clot. So if platelets are low, you might have problems with bleeding. And if platelets are high, you actually might have problems with excessive clotting. So what do we do if the platelets are low? Again, if in the context of an illness, you could frequently see low platelets. And we already mentioned Lyme disease and anaplasmosis. This time of year, I'm starting to see that those illnesses will make the platelet count go low. I don't know why. They probably just suppress the bone marrow as among many other things. And viruses also can suppress the bone marrow and make the platelet count go low. Sometimes you do a CBC. You're here for your physical. I'm doing a CBC. I know it's not evidence-based, but I'm doing it anyway. And I get a low platelet count. By the way, normal can vary. It depends on your lab. Probably between 150 and 450, somewhere in there. So sometimes you do it comes back at 100. Well, you really don't have problems with bleeding until it gets much lower. Probably about 30. Would you agree with that?
Yeah.
And some people can just have low platelets, kind of that upside-down U-shaped curve that we talked about, or the horseshoe. Sometimes, especially in kids, they'll come in. This is not, they'll come in and they got these little red or purplish dots on all over their body, and the parent says, "What's wrong with this kid?" And we do a platelet count. It could be amazingly low, 5, 6. Do you know what that diagnosis would be?
Autoimmune thrombocytopenia.
Right, ITP.
ITP, yeah.
So idiopathic thrombocytopenia purpura. And it's treatable, all right, but it's a serious condition. And it tends to be more of a pediatric thing, or at least a young adult thing. But that is usually a patient has to be hospitalized, at risk of serious bleeding, and has to have various treatments to have that fixed. Some people can have a chronic ITP, chronic autoimmune thrombocytopenia. Basically, that means your body has made platelets, antibodies to the platelets, and is kind of destroying them, basically. And, these people can just walk around with it. I got patients, their platelet counts are 80, 70. They're followed by a hematologist, but there's not much to do other than just check the blood counts periodically.
Is that medicines like Coumadin are affecting platelets? Is that?
No, but the reason we clot is very complicated. You have platelets, and you need platelets. You also have clotting factors that you need as well. So, for example, hemophilia. Those are boys that are born with a lack of a clotting factor, and they therefore have bleeding. So Coumadin, or another ones was warfarin, and then the newer ones like Eliquis and Xarelto. A lot of people are on these meds, are all over the television. They interfere with the clotting part, not the platelet part.
Gotcha.
But if someone's walking around with platelets of 20 and they happen to have AFib, for example, atrial fibrillation, they probably shouldn't go on Coumadin because they already got low platelets. That's complicated when people have complicated problems like that. And what do high platelets mean? Well, platelets are one of many inflammatory mediators. We use that term, inflammatory mediators. So if you're acutely ill with something, the platelets can go very high, 400, 500, 600, 700. I mean, and then you want to find the other underlying diagnosis. Some people can just have what's called essential thrombocytosis or thrombocythemia. It's almost like a leukemia of your platelets. Your body is making more platelets, and that also can happen. And that's a sort of I think it's classified as a myeloproliferative disorder. So in other words, it's not quite cancer or leukemia, but it's also something that I would refer the patient to a hematologist for.
So what happens to you when that happens?
Well, you can have clots, strokes, clots in your leg, clots in your lung, and there is treatment. Most commonly a medication, I have no idea how it works, called hydroxyurea. But there are some newer meds out there too. That, again, this is hematology stuff. We have a patient, Molly saw the patient last week with sickle cell anemia, which we didn't really discuss. That's obviously a type of anemia because it's in the name of the disease. And these are people of African descent, almost 100%. Maybe there's rare cases, and they lack a gene, a very specific gene that helps them make the right type of hemoglobin. So as a result, they are chronically anemic. And the cells sickle. They kind of turn into like little discs, and they get stuck in the blood vessels, and it's very painful. That's called a sickle cell crisis. So this patient, Molly, we struggle with that, how to keep him out of that crisis. And it's a very challenging case.
Causes a lot of pain, right?
Yeah. Sickle cell anemia, I believe, is part of the neonatal screen of every newborn in the country. Every state, I think, has laws like this too. There's a panel of illnesses that newborns are screened for, and sickle cell is one of them, because you really want to make that diagnosis right away to get the proper treatment. Okay, so have I
white blood cells, red blood cells, platelets.
That's I think we did a good little primer on hematology. So when your doctor runs a CBC and you're told you're a little anemic, you may not have a diagnosis, but there should be a plan. Yeah, all right, the plan should be we're going to check it again in 3 months, 6 months. I want to send you to a GI doctor. I want to make sure that you're up to date with your gynecology health. I mean, I would just want to know that patients, or when they're told something is a little abnormal, that they're at least a plan. The plan might be to watch it.
These things don't really resolve on their own, usually.
Which things? No. I think transient fluctuate. Again, we said, for example, a white count was normal was maybe 11 or less. So it comes back at 13. 14, and not much of a big deal there. That could be just a transient thing. And who knows why Allergies, I've seen it. Anything that's causing inflammation in the body can raise the white blood cells. And so you don't necessarily have to get too excited over an abnormal lab. You just have to have a plan in place. And that's, that's something in the bigger scale that's always a challenge, I think, for doctors' offices is how to reach out to patients in a timely fashion with a acceptable explanation of your labs. It's something we I've been doing this for around 25 years right now. So it was an issue 25 years ago, and there's some improvement with the portal. People, but we're having a little bit of a problem with people can sometimes see their labs before I see their labs, and therefore they're looking at their labs out of context and without really the understanding. It could lead to anxiety and even some panic. I think it's a good rule that if you have a test done, I think you should hear something within about a week. You have to watch out for the lab, by the way. They like to draw the lab, and then they like to say, "Oh, he'll have the results tomorrow." I'm like, "I will." Why are you doing that to my patients? First of all, maybe tomorrow, maybe not tomorrow. It still takes some time in the office to review labs and kind of come up with a plan. So I think a week is a fair amount of time. But no news is not necessarily good news. No news can be a misplaced lab that I never got. And there's really no good system for that. If a lab is out there and I never got the result, I don't have a good system in place to tell me of that. What to do about it. So it's it's kind of something Molly's probably heard me say it to patients. Take about a week. You should hear something. You will hear something from us. It might simply be the nurse saying everything was normal, whatever. But the portal is kind of a gift and a curse. What else is new, right? Things are usually like that. And there's some rules going on that patients are entitled to immediate results, which on one level sounds good, but on the other level, you don't know what you're looking at. So it's leading to some confusion. Maybe these are isolated cases and I'm blowing them out of proportion, but we'll see where it goes.
So the lab just sends the results right to the patient?
If I order the lab, it comes into me electronically. But the patients have a patient portal. This was, I believe, part of the Obamacare, way to communicate with your healthcare provider electronically. Again, a gift and a curse. And one of the things is you're able to actually see your whole record too, which is okay. I think it's their record. People have a kind of a right and legal right to see their record, but things sometimes need context, and I've had patients get upset over things like, for example, obesity. You're obese. It's in your chart. It's a diagnosis. It may upset you, or just things, anxiety, things that we'll say in a chart that maybe a patient will get upset about.
I had a patient get upset over the fact that there was a diagnosis of giddiness in their chart. And they wanted to know what that was and why it was in there. And of course, I didn't know. So I Googled it, and it just means dizzy, right?
Right.
You're dizzy.
Right. I can order, if a patient comes in complaining of dizziness, the Medicare term is dizziness and giddiness. So, I usually do some basic labs. But yeah, see, that's a good example.
I wasn't laughing. They were like, I wasn't laughing in there or being silly.
You weren't giggling. Right. So I think it's not an issue of too much knowledge. I think it's just an issue of context. And I had to bring my mother to an attorney last week to talk about some stuff. It was complicated. I had to see, it's kind of like the analogous to that, So, So anyway, that's something that we're kind of dealing with. We we always talk about etiquette, at our on the show here, kind of a two-way street etiquette. There's provider etiquette and there's patient etiquette. So I think patient etiquette, a little, patience with getting your results, but no news is not necessarily good news. Some people, I ordered these labs 6 months ago. They finally get them, and 12 hours later, what are the results? So it's like, I can't even remember why I ordered the test. I have to kind of go through my records.
Right. You often say that I got a quick question, but there's no quick questions.
No, I say, unless you can ask me what time it is, there are no quick questions. And because this is what's called doorknobbers. Again, not a new term. This is this stuff. You're literally on the door. Your hands on the doorknob. The visit's over, and the patient goes, "One more thing." A lot of times, men will save their request for erectile dysfunction meds to the end of the visit, which is, again, not a quick question. It's still, but sometimes it's also something bigger. The chest pain or something that might be indicative of something more serious. So I think it's good etiquette to really make your agenda presented to the provider at the beginning of the visit, not at the end of the visit. And we talked, I think it was last week, about the list, when patients have a list, how challenging that could be to, in the context of a wellness visit, I'm supposed to, and this is a 30-minute slot, that of which about 15 to 20 minutes is time with me. Supposed to review their wellness, are they due for things, or, review things like smoking cessation, diet, cut back on alcohol, things like that. Review their chronic problems, their, hypertension, whatever. And then patients will kind of have new things they want to bring up. It's a lot of ground to cover in one visit.
Right. My shoulder hurts. Right. My daughter's husband left her.
Sometimes
there's a lot.
And I do what a little bit, sometimes Molly saw this, a little bit of the schmooze factor that I do with primary care. I think it's just part of primary care. How things going, how's your job,
That's what's comforting about having a primary care doctor, that they do know who you are and they ask how your kids are, and they have some idea of what you're up against when you walk in. So it's kind of comfortable.
Yeah.
So, but when you were ordering labs, do you ever have an issue with things being covered?
Yeah, absolutely. And you remember the movie Rain Man? I mean, I have these codes are in my head because I have to memorize them to attach them to ordering. You can't just order stuff. Medicare was the one that started this. Again, and there's one of many vain attempts to control cost. Obviously the Medicare budget was being drained because Dr. Stamberg in Kingston, New York was ordering too many B12 levels. Come on. But you don't always know why if Medicare is going to agree with you. I wasted an hour of my Tuesday last week on the phone with one of the labs trying to get a patient's PSA covered, which is the prostate test. I'm still not sure what the issue is. After talking to various people, they said, "Well, we'll resubmit it." I was like, "Okay, I don't." So it's very, very frustrating. Yeah, you have to play alphabets. Well, it's not alphabet; they're numbers and letters.
Right, and I'm not really sure. Like the listening audience is aware that every blood test that's ordered is attached to a code, which is attached to a diagnosis.
Right.
And you can't just make something up. Like if Medicare says that this particular test is only covered under one specific diagnosis and the patient doesn't actually have that diagnosis, you can't say that they do because that's fraud. So,
right.
Right.
And by the way, this because it's kind of like guessing game of not being sure. Had Medicare said, "Oh yeah, that is a little bit of a problem," so their solution was something called an ABN, which is
Advanced Beneficiary Notification.
Right. So basically, the beneficiary, which is the patient, has to sign something saying Medicare may not cover this, and I agree to pay for it. Well, sometimes they then say, well, I'm not getting it done. Well, that's a problem because I want this test done. I ordered it. So already we're having kind of a conflict between what I think is best for the patient. And, it's just kind of a guessing game. I've gotten kind of good at it over the years, but every now and then something comes up. And also there's also human error. When I order the lab, and then fax it out and send it over to one of our community labs. They, whoever's drawing it has to enter those diagnoses, and sometimes one gets dropped or entered incorrectly or whatever. And
human beings.
Human error. So this is a pretty complicated process, but I really think that our financial problems with medicine are much more complicated than the fact that I'm ordering B12 levels on patients. So a little context here.
Right, or PSAs.
Yeah. By the way, it didn't work. It did it. I mean, the cost continued to go up. So all it did was make things more complicated. So thank you.
Well, let's have another show, right? That's a big topic.
The weekly kvetch.
Well, I don't know. I think this is something that affects everyone. I mean,
it does.
Right. Because everyone who's going to the doctor, everyone who's getting labs done, and kind of everyone has always been in that situation where you're like, it's not covered. Right. What do you mean it's not covered? Right. And then it's like a panic. Oh, yeah. And then it's like, my doctor did it wrong. Right. But you have to understand that sometimes the doctor, first of all, is guessing at what, they have to put down the diagnosis that applies to you. So it has to be something that is actually wrong with you. And then is that diagnosis actually covered? And then sometimes the rules change and a diagnosis that used to be covered isn't covered anymore.
Right.
So this is back to that team thing, like you and your doctor being a team.
Right.
If he wants the test done and he wants it covered. You have to just take that as a given.
Right, because it's very anxiety. All of a sudden you get a bill, and it's a lot of money. I had a patient where she got a bill, and it I intervened. I don't know why, because it wasn't my fault at all. It turned out that the lab had the wrong insurance information. So it wasn't a coding problem at all. It was again human error. Whoever entered that insurance and it was going to the wrong insurance company, and that's why I wasn't getting paid.
Right. So that's what we always say, like, just take a breath.
Take a breath.
Call the office. Everyone's there to help you. So
I'll say to patients, I actually go to great efforts to make sure that the tests I order are attached to appropriate diagnosis. And if something there's a problem, just get me a copy. Don't panic. Don't call in a huff and a puff. Don't barge in. That happens sometimes too. Maybe pre-COVID days, but don't do the barge in. You just, you got a PSR or a receptionist up front. She doesn't know what's going on with this.
The receptionist has no idea what's going on.
No, so it's not fair to barge in and put this in the lap of the receptionist. Take a deep breath, get me a copy of it. I'll review it. And almost always there's just some easily explained explanation. But, a couple of years ago, remember, I keep talking about B12, but anyway, I used to order for a diagnosis of fatigue. Well, Medicare decided, maybe it was 2018 or whatever, that they weren't going to do that. So covered it. So all of a sudden, all these B12s weren't being covered, and I had to, they do it for memory impairment, gait. Again, I'll say to a patient, look, you forget things sometimes? The guy goes, yes. I go, okay, I'm going to put memory impairment. Don't get upset. You don't have dementia. But, I think, we just got to make sure this level's, good. Because if it's low, it might be affecting you. Am I giving away too much knowledge on how to play the Medicare game?
Right. Oh, wait. It's covered for low B12, right? Or
yes.
If you're B12 deficient,
right.
The test is covered.
Of course.
But you can't find out if the patient is B12 deficient until you run the test. So,
bingo.
Right.
Yes.
Kind of a catch-22 there.
We did talk a couple weeks ago about vitamin D. I'm going to dig up my source and show it to Molly, but the evidence is not really there to support vitamin D screening. I think the explanation really should just be, that we should all be taking some vitamin D supplements. But we know it's good for bones, but all these other claims are just all theoretical, memory, cardiac health, whatever, So that's coming up a lot too, vitamin D being checked. And that's a good example. Medicare's not going to cover it unless someone is deficient. Well, I don't know if they're deficient until I order a test. And that's it's also a great example of triangulation, right? Remember, so the three entities. And then in a way, this is almost quadrangulation because there's this fourth entity. So you have the patient, that's one. You have the provider, which is me. You have the payer, which could be Medicare or insurance company. That's the triangle. But you also have the lab, so it gets even more complicated.
Right, and with medication, then you have the pharmacy.
You're right.
So, and all of these things like having to work together, right?
Right. So in triangulation, it's dysfunctional. So the fact that the patient might wind up at odds with the doctor when really the problem is with the payer. It's one of our themes of our show, which is that to view your doctor or your healthcare provider as your partner in healthcare. I'm not on a mission to order a bunch of tests that won't be covered. That's not my goal.
Right. So, or prescribe a medication that's not covered. Or
Right.
I had a patient call just last week and was saying, the medication was not covered. They were up in arms. They've been taking this medication forever. Now they're being told by the pharmacy they have to take something else, and they don't want to take something else.
Right.
Whatever they're taking is working for them. And, I said to the patient quite calmly, just trying to keep everything so no one gets amped up. Did you think that your doctor ordered this medication for you and doesn't want it to be covered?
Right.
I mean, is that what you think? And the patient said, yes, that's what I think. And I was like, well, that's not true.
I'm sitting there going, let's see how I can make this person aggravated.
I said, it's your insurance company. Probably you have to look into it with the pharmacy. And they did. And actually it resolved itself, but it was, it's anxiety provoking.
Very anxiety provoking.
Right.
I had it with
Very
a
upsetting.
I'll tell a little vignette after our break about what happened in the office with a patient I didn't even see. Went to the ER, and how that also problem resolved itself. Amazing.
331-9255, right, Dan? You guys call in with your questions.
Yes. And we're going to go to our break in about 17 seconds. Should we count down?
I'm
really not good at this radio
and we'll
thing.
do birthdays when we get back.
Oh, no, let's see. Oh, look, yes, we have birthdays.
Molly, this is going to be great.
Oh, Molly, you don't know what you're in for. All right, we'll see you after the break.
Okay, thank you, Dr. Eric Stamberg, Robin Baker, and Molly Goodman. Thank you so much for being in with us today. And this is Medical Monday, and it is Monday, April 12th, and 46 degrees now here in Uptown Kingston. You are listening to Kingston Community Radio, AM 920 and 92.5 FM, WGHQ, and streaming online live at mykcr.org. Considerably cloudy today with occasional rain showers, a high around 50% chance of rain throughout the day. And tonight, 40% chance of showers early, cloudy overnight, low of 38. And Tuesday, partly sunny, partly cloudy, a high of 64. And Tuesday night, generally fair, low of 41. And Wednesday, sun in the morning with cloudiness increasing in the afternoon. Wednesday night, 70% chance of showers early, then becoming steady rain overnight. A low of 43, that's for Wednesday night. And we'll be right back.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5.
Central Hudson reminds you, when it comes to your home's wiring, safety matters. Overheated electric cords or outlets are signs of inadequate wiring, within your wall, in an appliance, or both. Circuit breakers or fuses that trip often is usually a sign that a circuit is overloaded, an appliance is faulty, or something is wrong that can shock a person or cause a fire. Have a trained electrician troubleshoot such problems immediately.
Hey, so what's a great way to spread awareness that driving high is illegal everywhere? A catchy song, of course.
You can run, but you can't drive high. You can run, but you can't drive high.
Friendly reminder, don't drive high. If you feel different, you drive different. Brought to you by NHTSA and the Ad Council.
Hi, this is Cameron Rylands from Kingston, and I support Kingston Community Radio because it's informative.
This last portion of Kingston Community Radio was brought to you by Central Hudson. This upcoming portion of Kingston Community Radio is brought to you by Herzog's. Do you ever think about what really matters? At Herzog's Home and Paint Centers, Community, family, neighborhood all matter. Herzog's employees have been a part of the Herzog's family for years, and they value personal customer service and being close to their community. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building, maintenance, and painting needs, and discover the difference of buying local. Sales ongoing at herzogs.com. Equal housing lend. I'm sorry. You're listening to WGHQ AM 920, 92.5 FM, and streaming online at mykcr.org. It's Monday, April 12th, and 46 degrees here in Uptown Kingston. Keep us busy. 331-9255 is your number to call in. And let's get back to the on-air studio with Dr. Eric Stamberg, Robin Baker, and Molly Goodman for this segment of Kingston Community Radio's Medical Monday.
All right, welcome to the second hour of this morning's show. We are going to do our birthday, and this is we told Molly, you just don't know the excitement you're in for. So let's get ready.
There's a script here.
All right, we have only one, so this is the winner. Robin, with your lovely radio voice, please announce.
Hey.
Here, Molly, you can ring that bell.
Happy birthday is brought to you by, is it brought to us by Boyce Dairy Milk House?
It is brought to us by Boyce Dairy Milk House.
Also, the prize comes from Boyce Dairy Milk House, 62 O'Neill Street in Kingston. It is a famous cow pie. If you had never had a cow pie, they are famous.
You're in town, you got to get a cow pie.
And happy birthday to Jackson Steltz from Dad, family, and friends. Jackson, happy birthday. And Jackson, you're the only birthday today, so you're a big winner. Happy birthday.
All right.
Jackson, so you just go by Boyce's Dairy Milk House today. Tell them that you're the big winner of the birthday prize, and you can get your, I think they have them pre-made, or you can make it up as you go. You can pick what ice creams you want and what toppings.
Yes.
Kind of like a big sundae.
It's
in the shape of a pie.
I guess so.
This is like an ice cream cake. This is an ice cream pie.
Right.
I grew up on a farm.
Yeah.
Cow pies weren't.
No, they
were not good.
Right.
Yeah. So you got a couple events happening too.
Yes. I'll go first here. The 12th annual Kingston Clean Sweep takes place Saturday, May 1st. What is it? Volunteers will be picking up litter along the Kingston corridor from the railroad crossing in Washington Ave to the Uptown Business District. Excuse me. Okay. Down Broadway to the Rondout waterfront, as well as some side streets. So it's, following groups have committed: the Friends of the Kingston Area Library, Hudson River Maritime Museum, Kingston Rotary, Junior League of Kingston, Kingston Kiwanis. How do I get to be a Kiwanis?
I know you would love to do that. The musical, the
What music?
Capers, the Kiwanis Capers.
All right,
those guys have a lot of fun.
Kingston Uptown Business Association, Kingston Catholic School, City Hall, Friends of Historic Kingston, and Ulster Garden Club. If interested, contact Friends of Historic Kingston at 339-0720 or Anna Brett, chair at abrett1@verizon.net.
That sounds like a lot of fun. Just picking up the garbage.
Well, you're doing a mitzvah. In my neighborhood, we call that a mitzvah.
A good deed.
A good deed.
Community Action Farm Stand is coming to Saugerties, free to those in need, beginning on Friday, April 23rd, every fourth Friday of the month thereafter, from 10 a.m. to 1 until supplies last. This is going to be held at the Saugerties Senior Citizen Center parking lot. Give always with representatives from our weatherization and Power Head Start programs available for information and questions. And just remember, contact-free pickup is available. Remember to wear your mask, follow directions, and remain in your vehicle at all times for the safety of yourself and our staff and volunteers. Staff will place items in your vehicle trunk, so please have it clean and leave us room. I guess there's a lot of vegetables going to be going in your car. So beginning Friday the 23rd of April and every fourth Friday of the month thereafter from 10 to 1.
What is it?
It is a community action farm stand. So you're getting some yummy, I guess, in-season
vegetables. That'd be the same
vegetables.
thing then.
Yeah, I think it's the same thing.
What's the location?
Oh, you can go to the Saugerties Senior Center parking lot. Does it have an address there, Eric?
Let's see. 207 Market Street, Saugerties. No, there's
Saugerties,
no address.
Saugerties Senior Center, 207 Market Street.
In the middle of the piece of paper. All right, what's the last one?
So the last one is that the YMCA is accepting bicycles for reuse. So the YMCA of Kingston, Ulster County is calling for donations of gently used adult bicycles to meet the demands of local residents who need basic transportation. Through the YMCA's Lend a Wheel bicycle reuse program, bikes are given to essential workers and any low to moderate income resident of Ulster County who needs a bike. The Lend a Wheel program offers bike locks, helmets, lights, and bells. The YMCA sees a great community need for used bicycles that can be fixed and recycled through the program. We give out hundreds of bikes since Lend a Wheel started in 2014, but today we have more people than bikes to go around. We could really use your old mountain bike or hybrid with 24-inch wheels or bigger. This is according to Tom Polk, the YMCA bicycle program manager. Unfortunately, they can't use racing-style 10-speeds or bikes for children. So for details on how to donate and what's accepted, you can see the attached donation guidelines or contact Polk at 845-338-3810, extension 102, or Polk, TPOLK, at ymcaulster.org. Sounds like a great idea.
What was the extension? I have a bike to donate. What's the extension again for Tom? Sorry.
That's okay. It's 102. So it's 845-338-3810, extension 102.
You have any bikes to donate?
I do have a couple bikes, actually, that no one's using.
Maybe we should. Okay, let's talk about that, because you and I talked about maybe getting bikes. And all right, so second half of this morning's show, just very quick vignette about experience last week, okay? A patient called the office saying he had a history of clots in his leg, and he felt he had another one. Well, you know, it was later in the week, so it really wasn't practical for me to try to arrange an outpatient test, unfortunately, because the weekend was coming. So he went up in the ER where they did an ultrasound, which confirmed a clot. And I used to be in admission, by the way. Patients used to get admitted. We would treat them with heparin and then heparin's a blood thinner, and start them over onto warfarin. As time went on, most clots don't need to be admitted. It's outpatient management. The preferred treatment is what's called a novel anticoagulant. There's two main brands there, Eliquis and Xarelto. There's actually a third called Pradaxa that kind of has fallen out of favor, which is the one that your experience was that they complained they saw more bleeding. Xarelto.
Yeah.
All right, so there might be some, at least amongst surgeons and other specialists, they feel that Xarelto is associated with more adverse bleeding. All right, it's kind of anecdotal. We could maybe try to see if there's a evidence behind it. By the way, there's an antidote to those, right? Mm-hmm. And in other words, if you're kind of bleeding and you're on one of these, you could be given a medication to reverse that. Anyway, so he was prescribed Eliquis, which is standard of care. These newer meds are probably more effective than warfarin or Coumadin. They're probably safer than warfarin or Coumadin, and warfarin. Goodman is just a brand of warfarin, and you have to constantly monitor it. You have to constantly check levels. The dose is too high, dose is too low. It's a big headache, to be honest.
The INR.
Yeah, INR. So these new meds are really kind of game changers. They really they're probably better meds. They're easier to manage, so on and so forth. Anyway,
Doc, what's happening to the blood if it's thinning? What are you doing to the blood with these medications?
Well, you're number one, trying to prevent this clot from propagating, getting larger. And the dreaded complication of a clot in the leg, other than causing discomfort, is that it can break loose and travel to the lungs. That's called a pulmonary embolus, and that can be
fatal, right? Fatal,
actually, yes. It's serious. Not always an easy diagnosis. A test is done in the emergency room a lot now called a CT angio, a specific test. We used to not have that test. It was a much harder diagnosis. You used to do something called a VQ scan. It wasn't even it was a really flawed technology. Anyway, so that's what we worry about. Okay. So the blood thinner, that's what's commonly called, prevents the clot from getting bigger. Therefore, prevents it from breaking loose, and then will also help dissolve the clot over time. Some people, it never goes away completely. They have just what's called a chronic DVT, and that maybe we have a guest coming next week. Maybe we'll talk a little bit about that. He's a hematologist, hematology oncology specialist, and it's a pretty common reason for patients to see a hematologist if they have a clot, to decide if they have some sort of genetic predilection for the clot. I just wanted to throw that word into a conversation. And really, how long? You know, with an ultrasound, the clot diagnosis are kind of easy. The issue is, and it's easy to start the treatment. The issue is how long should they be on it? 3 months, 6 months, forever.
Can you take a clot out, like surgically?
Yeah, they what's called a thrombectomy. And they do that over at Vassar. You know what? But to me, this is kind of new stuff. You know, I'm a community family practitioner. You know, when I know some inpatients that have been presented to Northern Dutchess and then transferred over to Vassar to have this done. I'm not quite sure. Do you know what would be an indication to do that rather than just put the person on Eliquis?
I think that if it's something that's life-threatening, or if you have a thrombosis that can cause ischemia, which is when you cut off blood supply to an organ, or say you have lower extremity ischemia, the blood clot has gotten so serious that maybe it could threaten a limb. So basically, if it's not enough time to allow the clot to dissolve via medication, you would probably do a thrombectomy.
Wasn't that a good answer?
Yes, it was.
Anyway, so this patient was prescribed Eliquis and then tried to get it filled. And then I'll leave it out. All blank broke loose. You know, the pharmacy, it needs an authorization. You know, well, now it's put me in an awkward situation because I haven't even seen this patient. You know, and then to make a long story short, after many, many phone calls that my poor nurse Alex had to occupy too much of her time with during the day, we found that it did not need a prior authorization. I don't know what's going on. You know, but it just kind of this epidemic of misinformation from this chaotic health industry that we have, you know, and he was able to get his med, and they'll be doing a follow-up with us this week, so maybe we'll see him. So,
right, I mean, that's horrible, though, for a patient that has a diagnosis like that, and then can't get their medication.
Absolutely.
It's so upsetting.
And it's it's a new medicine. It's very expensive, you know, so it's not even I'll get a week's worth until it's figured out. I mean, you're talking hundreds of dollars. You know, it's a real problem, but just this kind of chaos. Does it need it? Does it not need it? Oh, a message came through saying it has to be a different dose. The patient sent me the message, and I said, well, that dose is not the right dose for you. You know, dose is a lower dose for someone who has maybe some kidney problems or an older patient. So even then, that was sending miscommunication. And then at the end of the day, we just kind of. The answer was, Alex found out that it doesn't require authorization. So who knows is the answer.
So what is the protocol when you're seen in the ER and you're discharged, basically, and you're told to do XYZ, and there is a problem? I mean, that falls on your primary. What if you don't have a primary care doctor? Then, because I know the hospital is done with you at this point. It's not like you can call the hospital and have that doctor take care of something for you.
Right. Well, the one message is you should have a primary care doctor. But you're right. It is a potential problem where someone has something prescribed by the ER, the hospital. They get discharged from the hospital, so, and then all of a sudden something needs to be authorized, and it can really result in delay of care and potential and harmful delay of care. So it's a big problem. That's what happens.
What does a patient do in that situation?
I would enlist your primary care, but really, it's always best done in the context of an encounter. If I'm going to try to get something authorized, it's got to go. I want to make my case for it, so you should, in this case, I was gonna, kind of have the patient do a kind of an urgent telephone appointment, document everything, and then we were going to get it authorized, but it wound up being,
a mistake.
Whatever, wherever this miscommunication comes from, it's sad, to be honest with you. That's what happens. Anyway. We have in our office today Molly Goodman. Molly Goodman is a third-year medical student over at Toro Medical College. Is that what it's called?
Mm-hmm.
It's in Middletown, although there's another campus for this school. Where, in Harlem?
In Harlem, yeah.
And so, Molly's finishing her end of her third year. This is a very exciting time because she's done all of her clinical rotations. She's finishing up with primary care. Primary care is always a good first rotation or last rotation, kind of bring it all together. But she's done surgery, OBGYN, internal medicine, psychiatry, pediatrics. Those are kind of what they call the core,
Gastroenterology?
Well, that's more of an elective or specialty.
Yeah, I did, yeah.
But you would be exposed to that during internal medicine and maybe primary care, depends on, So what's your take home? How's your medical education been going?
It's good. I actually read an article the other day that medical school applications have post-COVID, or not post, sorry, it's not over, but
COVID
because
era.
of COVID, in the COVID era has actually gone up 20%. And I think that COVID has actually inspired a lot of people to go into healthcare because I think that, this is me just, theorizing, but I think that people in the era of COVID have realized, how tough it is to be a healthcare provider. And I think that they kind of maybe see that as a little bit admirable. So I think that's what has made medical school admissions or not admissions, but applications to go up. Yeah.
No, I agree with that. I think we have been referred to as heroes, for example. By the way, I don't think I'm a hero. I think, but these doctors and nurses out in the ICUs and the emergency rooms that all day long of having to put full PPE on to go take care of patients. And stories of a couple of them getting sick and even passing away. They're the heroes. That's what.
Yeah, very difficult. Some of them staying away from their families for months at a time.
Right.
When this was happening, really tough.
Right. So the fact that I wonder if the same trend is present with nursing up. I don't know. We'd have to. I wonder. Well, the healthcare projections are that there's going to be a shortage of doctors. I'm always a little skeptical about that because when they say there's a shortage, it varies. I mean, there's technically usually not a shortage in cities like Boston or Manhattan, and sometimes it's more of a distribution problem. So we have a bigger problem, which is getting young physicians to maybe go to a community that needs them, but in a place that maybe the young physician does not want to go.
Right.
Anyway, so what do you think? How was your medical education? How's it going?
I think it's going great. How medical school generally goes is you have the first 2 years are classrooms. So you sit in a classroom, you take tests, and it's like traditional classroom work.
Boring.
Yeah. And then the last 2 years are what are called your clinical years, where you essentially kind of learn what it's like to be every different type of doctor. Right. And then at the end of your third year, you're supposed to pick what kind of doctor you want to be. And you apply to go into what's called residency, which is the next step after medical school, after you've picked what kind of doctor you want to be. And I think that universally, most medical students find the clinical years more exciting because you spent all your time, high school, college, all that stuff in the classroom, and then you get to med school, you have to do 2 more years of, classroom work in med school. And finally, in your third year, you get to kind of apply everything that you've learned since the dawn of time to actual, clinical scenarios. So I think that this year's probably been the most fun and probably most, I wouldn't say thought-provoking, but I guess kind of more like mentally challenging in a way year for me than it has been in the past. I mean, in terms of like emotionally or mentally exhausting, I think the first 2 years are more mentally exhausting, but in terms of actually challenging myself, I feel like the third year has been the most. Mm-hmm.
Okay, and that really sums up my med school experience.
Mm-hmm.
The first 2 years, they're tough. Mm-hmm. A lot of classroom learning, a lot of exams. We would have kind of one serious exam per week, and they even designed it that way. So every week, we usually built up to a big exam on Friday, and it was stressful, And then the third year, kind of finally out in the hospitals, and it's interesting because I think criticisms of traditional education that I heard 25 years ago, 30 years ago, are still kind of present. Is the education's too hospital based, for example. Although most residencies are hospital-based, so, and I'm also a little critical of not enough emphasis on nutrition. We talked earlier in the show about wellness, for example. So one of the traditional med school courses is biochemistry. Now, biochemistry is pretty. She probably knows all about it, but it's pretty out there. A lot of it, and for the most part, it's not relevant to what I do every day, or even to what most doctors do every day. And I just think that if we could morph that into more of a wellness, nutrition course, because in a way that's what biochemistry kind of is: amino acids, carbohydrates, things like that. So I'd like to see them kind of get away from biochemistry, make it more of a nutrition and wellness type curriculum. Starting in first year, and that's my little editorial.
Well, nutrition can help patients in so many different ways, right? I mean,
yeah,
adjusting someone's nutrition can change their life and their health.
And it's more in context of what we're going to be doing when we're finally done with residency and doctors, rather than memorizing the Krebs cycle for the 100th time. Have you ever heard the Krebs cycle?
No.
It's pretty boring, but what is it? It's a metabolism of carbohydrates.
Yeah, and it's just one of these things that, for one reason, I can't explain why, but as soon as you learn it and you have to do it for the test, you just forget it again, and you have to relearn it every time. And for some reason, you never remember it the time before. I don't know. And it's like you think it's only you, but every medical professional you talk to, for some reason, you just can never remember it.
and you don't remember it because it never gets reinforced.
Yeah, exactly.
If something gets reinforced, you'll remember it, but. It's a lot of pre-med and, when you're in college and then even first 2 years of med school, a little bit sometimes what they call a weed out. Maybe not med school, because once you're in med school, the schools kind of want you to stay there.
Yeah.
But in college, if you're pre-med, there's competition. It's tough. And a course like that is kind of designed. Organic chemistry is the other one, too. It's kind of designed to say, all right, you got it or not? Because if you can't make it through this course, you don't got it. Even though most of what you're learning is not going to be relevant to being a physician. So, right? Would you agree with that?
Yeah, I would definitely agree with that. Because I know that a lot of colleges, especially if one of the main outputs that they have as a college is people going to med school. Like, for example, I went to University of Rochester, which has a really large medical center attached to a really big research center. I'm pretty sure that Harvard and University of Rochester are the two institutions in the country that put out the most research out of all institutions.
Isn't that amazing?
Yeah.
Rochester and Harvard.
Yeah. So I know that in my undergraduate experience, there's a lot of people doing pre-med. I don't remember exactly what the percentage, but it was a very large portion of the class. So the school would definitely try and make sure that only the people that they really thought would actually get into medical school would apply. It wasn't even I'm going to go to med school and I'm going to apply. You had to go through the college. They had to basically prove that you were going to apply to med school. They had to look over all your scores, look over your applications, and if they didn't think that you could get into med school, they would really discourage a lot of people from going to medical school. I have no idea how many friends that I have where they were told, you are not going to get into med school.
You got it.
You don't got it. You can't go. You should stop. And they're in med school now because they persevered, but they do definitely try and put people down if they don't think that they're going to go, because then they won't have stats on their website that say X amount percent
right. No,
into med school.
Colleges and universities do like to brag about that, whatever percentage of our pre-meds get into med school. So they have an investment to weed you out. Now, once you get into medical school, basically the school has basically said, we're accepting it. You got it. So, there were some colleagues of mine who did struggle a little bit, but the school, was invested in helping them out. They didn't want anyone to flunk out of med school. But that's the old joke, by the way. What do you call the guy that graduates last in his medical school class?
Doctor.
So,
Molly, why did you want to become a doctor?
As Dr. Stamberg knows this, so my father's a physician, so obviously that plays obviously a giant role in why I wanted to go to medical school.
My father's a hematologist, so if he's listening, I'm sure he's probably grading my
task today.
Yeah, yikes! Time to weed me out. All right, go on.
But I think another thing was when I was growing up, my parents were very into community service. So we did a lot of community service as a family when I was growing up. And so I think that when I got to college, I actually didn't really know what I wanted to do. I knew that, and it sounds cliche, I knew that I wanted to help people. but I didn't really know in what context I wanted to do that in. So I was like, you know what, I'll be a bio major. If anything, that's like find something that will get me some kind of job after I graduate. And then as I went through, I was like, you know what, I have always really gravitated towards science when I was younger. And then it kind of came to the decision of, yes, I want to go into healthcare, but do I want to be a PA? Do I want to be a nurse? Do I want to be a doctor? That's definitely a very individual decision for every person, which kind of healthcare provider that they want to be. But at the end of the day, for me, I felt like I would be in a best position and kind of like if it would fit my personality the most to go to medical school and to become a doctor. So it was kind of the combination of growing up and knowing that I always really wanted to serve my community and feeling comfortable in like being a leadership position that kind of led me to go to medical school. Mm-hmm.
She comes from rather medical family. Her father's a physician. Her mother is a nurse practitioner and a psychiatric nurse practitioner, which is a tough gig. Mm-hmm. And then she has two sisters who are both physicians. Mm-hmm. Where are your sisters?
So my oldest sister is a pediatrician. She's actually moving to Cincinnati like this week to start a new job at University of Cincinnati. And then my middle sister is a internal medicine resident at SUNY Upstate, which is in Syracuse. Mm-hmm.
So that's a medical family. Well, and you know, when I have a student, I usually don't ask them what they want to go into for two reasons. Although we're hearing our break, the one reason is I don't want them to have pressure to give the right answer. You know, remember, in a way, I'm going to grade her. You know, so I want to be. We all had colleagues. I want to be a surgeon, and then 2 months later, the guy's like, I want to be a pediatrician. Like, you know, the rest of us are like, oh boy, here he goes again. You know. And I also, you know, I don't want to approach students differently. You know, I don't be like, oh, good, you want to be a family practitioner? Come on. You know, I want to treat everyone the same. But Molly's at the end of her third year, which means she kind of has decided because she has to start applying to residencies within a month or, you know, within 2 or 3 months. Mm-hmm. So we're going to visit that a little bit after the break.
Thank you. And thank you, Dr. Eric Stamberg, and thank you, Robin Baker, and also third-year medical student, Molly Goodman. Thank you for being with us today on Medical Monday, and we thank you, listeners, for being with us. It's now at the bottom of the hour. You're with us on Kingston Community Radio, KCR, AM 920 and 92.5 FM, WGHQ, and streaming online at mykcr.org. Monday, April 12th, and it's 46 degrees now here in Uptown Kingston. This last portion of Kingston Community Radio has been brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building, maintenance, and painting needs. Discover the difference of buying local. Sales ongoing also at herzogs.com. Mid-Hudson Valley weather and forecast one more time. Considerably cloudy today with occasional rain showers throughout the day, a high of 50. Tonight, 40% chance of showers early, cloudy overnight, a low of 38. Tuesday, partly sunny, partly cloudy, a high of 64. Tuesday night, generally fair, low of 41. Wednesday, sunny in the morning, and with a little bit of cloudiness increasing in the afternoon. And Wednesday, 70% chance of showers early, becoming steady rain late, and a low of 43. We'll be right back after these messages.
Thanks for starting your day with Kingston Community Radio on 920 WGHQ AM Kingston and 92.5 W223CR FM Kingston, New York. Magic 92.5. Thanks for...
Honorary Forest Ranger Betty White here, lending a hand to my dear friend Smokey Bear, because for 75 years, he's only said,
only you can prevent wildfires.
But there's a lot more to say. Like, if you park your car on tall, dry grass, the hot exhaust pipe can start a wildfire. So be careful out there. Go to SmokeyBear.com to learn more about wildfire prevention. Brought to you by the U.S. Forest Service, your state forester, and the Ad Council.
We are Lions. We bring hope where it's needed. We are a global force for good. Support causes that matter. Change lives. Change communities. Change the world. We can do more together than we can alone. Join in. Experience the joy of serving. Be part of the movement. Give back. Let's unite the world for good. We are Lions. You can be too. Visit weserve.org.
Hi, this is Shirley Stabe from Kingston, and I support Kingston Community Radio, and so should you.
This last portion of Kingston Community Radio was brought to you by Herzog's. This upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. Monday, April 12th, 46 degrees right now here in Uptown Kingston. Kingston Community Radio is talk radio, 331-9255. Call in. And you are listening to AM 920, 92.5 FM, and or streaming online at mykcr.org. Let's get back to the on-air studio with Dr. Eric Stamberg, Robin Baker, and our guest, Molly Goodman. Welcome back.
Sitting there. All right, good morning. Welcome to the final installment of this morning's show. We have not had any callers today. Maybe the conversation's been so riveting.
Riveting.
Yes.
It's kind of unusual. I usually see this light up 6 or 7 times during the day, right? So, Come on, folks. You've got a question. It's your number, 331-9255.
Maybe our discussion about blood drained the blood from them. I was trying to come up with some jokes.
Blood jokes?
Blood jokes, yes.
I bet your Molly's dad has some.
I don't know. Is your father crack jokes?
Yeah.
Oh, all right.
Dad jokes are pretty standard. For dads.
A friend of hers who was a student came on the show a couple times. She used to say my jokes were cringeworthy. And I'd be like, that's not going to get you a good grade.
Yeah.
You laugh at the jokes and you don't complain. All right, anyway, so Molly, is it official that you've chosen what you're going to try to be resident in?
Yeah, so I'm interested in OBGYN. I think that for me, I went into med school not really knowing what I wanted to do, but I think I kind of was leaning more toward internal medicine, or maybe like family medicine, because off of it you can do like so many things. There's so many fellowships you can do off of it. But I did always have a huge interest in women's health, but the reason that I would never fully committed to OBGYN is because there's a lot of surgery in it. So I was like, I don't know if I want to do that much surgery. And I thought I was going to absolutely hate surgery. I thought it was going to be like the bane of my existence. And then I actually had my surgery rotation before I had my OBGYN rotation. And I was in the surgery rotation, and I was like, oh, I actually like this. Like, I thought I was going to hate this, but I actually really like it. So then when I got to my OBGYN rotation, I was like, well, actually, I like surgery even more in the context of OBGYN. So I think that at the end of the day, realizing that I actually like surgery, I liked it more in the context of OBGYN, and I like that kind of the variety you can get with OBGYN. So you can do surgery, you can do inpatient, you can do outpatient,
Right.
you do like primary care. There's like a lot of things that you do in OBGYN. Obviously, it's focused on women's health, but you can work in a lot of different settings. And you can do a lot of different things off of it, too. If you want to do a lot of endocrinology, you can
Right.
do infertility medicine. If you want to
Right.
do more kind
Oncology.
of... Yeah, you could do like oncology. If you want to just focus on, female cancers.
You could just do what they call high-risk OB. We have a
Yeah,
we
you
have
could
a
do
wonderful,
maternal fetal medicine.
wonderful doctor over at Vassar, Dr. Heller, who
Yeah.
kind of just focuses on women with some higher risk for her pregnancies, and but that's called maternal fetal medicine.
Right, yeah. So I think that I kind of like the variety that it can give you, and that because you have the surgical training and also the medicine training, there's just a lot of different things you can do off of it. So that's what I
I think the Goodman sisters should open a OBGYN pediatric internal medicine practice.
We have talked about this before.
Yeah, I think it's a great idea.
Yeah.
Get it all
Yeah.
covered, and I think that would be a wonderful model of healthcare. Well, OBGYN it's a challenging residency, right? I mean, most of when I was a med student, they seemed to be the most tired, and I want to say even the most cranky.
Yeah.
The surgery, they were also pretty tired, but there was something very, and I don't mean this just from gender terms, but macho about it. By the way, that's also changed. When 25 years ago, surgery residents were almost all male. Now it's still kind of male dominated, but probably 20 to 30% of surgery residents are women at this time. OBGYN, though, we used to, was probably, 75 to 80% women. But typically you're on call once every 3 nights, and you could deliveries all night long, run around catching babies, right? It's exciting. Family practice has that part of the training. Oh, we have a caller, but that's a kind of another topic. But we do have a caller.
Good morning.
Oh, good morning.
One of the things you did touch on earlier, which I was really glad you did, and that was about the platelets, because I do have abnormal platelets. And I was told if I ever had to have major surgery, I would have to have a transfusion of it. But I would like to go on another subject that you didn't touch, and that's about veins. And this is the problem I've had since I was young.
What?
Veins.
If I ever need to get, blood work done or anything like that, you got to go for veins, and you can get them very easily on either arm. It doesn't make any difference. But I have problems with the veins on my right arm, and I've had that since my late 20s. And like if somebody, you try to get blood work done, you can get the needle in fine, but then if I need an IV, sometimes the vein will collapse or it will infiltrate.
Right.
And then another thing happens too, like sometimes if they try, when they remove the needle, then, sometimes I'll get a bleed out from it. And it doesn't happen on my left arm, it's just on the right. And what would cause that to happen with the veins? Would you know?
So your platelets are fine.
My platelets aren't. I have abnormal platelets.
In what way? Are they high? Are they low?
They're low.
They're low. That's interesting. Hey, do you know how low?
I don't know. No.
Okay. Has it? Okay.
It's something I've always. It was something I was born with.
Okay. Well, there's a couple separate issues there. One is just you might be just what's called a tough stick, at least on the right side. Did you have any injury to the right arm when you were younger?
No. The only thing that I had trouble with, and I was told, okay, this goes back years ago. When my children was born, I had to have blood transfusion. And they gave me the first one in my left arm, which worked out okay. The right arm, when they tried it, and then they ran into problems. The vein collapsed, and then it infiltrated it, and then...
Sounds like one of our gigs here.
Yeah, so anyway, and the nurse at the hospital had said that, you're probably going to have trouble with that arm.
The bleeding during pregnancy and childbirth is interesting because a lot of women do have bleeding problems that won't manifest until they have a baby. And so the fact that you had to have transfusions does suggest that you had either low platelets or another bleeding problem. The fact that the veins on that side are there's a problem that's really hard to interpret. Sometimes you can have just routine blood draw can cause that vein to kind of clot up and never function again. By the way, we have alternative pathways. It's another part of our amazing creation. So if one vein has a problem, there's other veins that can kind of take over. But it sounds like you're just kind of a tough stick. They do okay when they use the left arm?
The left arm is fine. I never had any problems with that. It was just with the right. And I've had, as a child, what I used to have problems with bleeding, and where it showed up is with my gums. I couldn't even, if I would just smile, my gums would bleed. And I remember the dentist I would always go to and always would tell me, drink a lot of orange juice. And I did. And I used to, my foster mother used to make orange juice, fresh orange juice. And I used to eat the pulp out of the skins and all this stuff, And,
well, they're going for vitamin C there, but...
It's still, I would happen. And I remember one time the dentist, when I was like in my 20s and stuff like that, he had me go for... blood blood work, and they found out like my clotting time was off, and
How low are your platelets? Do you know the number?
I don't know the number on them, no. But I had to go up to Albany twice, and I had to have, special blood tests taken up there. And I knew, I stayed away from anything with aspirin compounds for years. I don't take anything because of it. And I know, like, a few times, like when I would go to my primary care doctor, and sometimes he'd tell me to take an Advil or or something, and I would say to him, well, I can't have that. It has aspirin compounds in it. I've had problems with bleeding in the past, and nobody ever asked me what it was, and they never sent me to find out what it was, and I did that myself. I went and had the blood work done, and then they found out that there was something wrong with my platelets, that they were too low, And then I was told if I ever have to have major surgery done, that I would need a transfusion of platelets.
So you might have what we call chronic ITP. We talked about that. In other words, your platelet counts just tend to be low, but in times of stress, it becomes an issue. Other than that, it's not much of an issue. There's also, it's an interesting story. I don't know what advice to give you about, or an explanation to give you about the difficulty with blood draw from the right arm. It just sounds like they got to use your left arm. But it's an interesting story that you're telling us.
The last time someone had the colonostomy too, and they wound up that they had used that arm, though, the right one. And then later on, when they removed the needle, and they had to go a couple times and put, that sponge thing, the cotton thing, and put a couple of different times because the thing it just soaked right through, So
right.
And even like I lost my train of thought. I'm sorry. But anyway, this has just been a problem all my life. I was born with the...
and interesting, it'd be nice to know specifically what your diagnosis is, but you said low platelets. It sounds like chronic ITP. We talked about that earlier.
Yeah, right.
An autoimmune problem that your body has lowered its platelets, and, it is what it is, but at times of stress, it becomes an issue.
Yeah, but even so, like in the past I had DNCs, and the way they used to do it years ago, had to go in the afternoon before for, the workup, and then one of the things they always did, I'd have a blood test taken, and then later on they come back in again, and they would take more blood from me, and I was always wondering, why are you always taking it twice? They didn't do it to anybody else. I had a couple other women in the same room, and I was the only one getting the blood taken twice, and.
Okay. Well, I appreciate your story and giving us a little context about what we were talking about earlier.
Yeah.
And thanks for listening.
Yeah, you're very welcome, and thanks for all the information you give out, and it's very helpful, and keep well, and and thanks again for everything.
All right, well, thank you very much.
Yeah, have a good day.
All right, bye-bye.
Okay, bye.
So, Molly, what would be... She's talking about her platelets, but that story of bleeding, particularly during childbirth, there's another kind of, I don't find it that common, the diagnosis, but they probably thought about
von Willebrand's.
Von Willebrand's disease, right, absolutely. Yeah. And that's kind of the story, that it does, a woman has excessive bleeding during childbirth and winds up, she mentioned her clotting time.
And the gums, too, is also a common
as well.
symptom.
But I don't, does von Willebrand's affect the platelets? I don't think so.
It affects, I don't think you get a low platelet value, but it affects the way that it clots, so it affects their function. Right. So it's kind of like you have low platelets because it doesn't allow them to work properly. But I'd have to double check this, but I'm pretty sure if you took a count of someone's platelets with von Willebrand's, I don't think they would be low.
Right. And maybe she has more just kind of dysfunctional platelets, but it's interesting. So von Willebrand's is kind of like hemophilia for women. It's just that hemophilia can be really a fatal condition if it's not treated properly. Von Willebrand's is also kind of a genetic clotting problem that someone can kind of just live with, but then at times of stress it might become an issue, like childbirth or an injury or something like that. Interesting. Surgery. Interesting story. So OBGYN, OBGYN is kind of like a pseudo primary care field as well. A lot of women, it's their only contact, and I generally think it's okay. I don't mind the younger women in my practice come say hi to me once a year. Because there's stuff to do. You check the blood pressure, and there could be a little redundancy with primary care and OBGYN, but it is okay. I mean, they do. It's a field of medicine that also does a lot of preventative care and therefore primary care and just the general health of women beyond just gynecologic issues. So, anyway, it was, for decades we said to women, every year get a PAP, every year, and women, they not all of them, but a lot of them said, okay, I'll do it every year, and now all of a sudden we kind of said, well, right? So for most women, how often they need to have PAPs?
It's like every 3.
Yeah, every 3.
Yeah.
And then it even gets more complicated
Yeah.
if they have HPV. If they don't have HPV, it could be every 5. Just every 3 is. But it's actually harder to keep track of something that's 3 years, versus 1.
It's kind of easier to do it every year.
Yeah. Oh, it's my birthday. I got to make my appointment.
Yeah.
That type of thing. So I hope that OBGYN practices have what they call a tickler system in place to kind of remind women to schedule it. I know GI practices do a pretty good job of reminding people when it's time for their next colonoscopy, for example. So that's something. But again, it's very common in my practice to ask women about their last GYN exam, and really, we were joking about the woman who says, I say, when was your last pap smear? And they'll say, oh, when I had my last kid. And I'll say, well, how old's the kid? And they'll say 18. I'll be, well, I think you do. So it's kind of like a two-way street. I find that, I can then steer my patients in the right direction and make sure they get the recommended health care. So.
You really do that as part of your practice anymore?
I don't for a couple of reasons. One was I just got a little bit older. Number 2 was I have the pleasure of sharing half of my office with an OBGYN department that I'm more than happy to refer the patients over to. And number 3 is my job got more complicated. The things I got to do. So in other words, this was something that I didn't necessarily even have the time for. There were some billing issues, in this wonderful industry of healthcare. So we used to do what's called, for women, and like when I was in private practice, over-under. We would have a woman come in for just a general physical, and then have her come back for a separate visit, which was her gynecology visit. Now, some insurance plans started to say to us, well, they're not paying for both. Basically, it's a preventative visit to their primary care, and so but most of them do cover an OBGYN visit. So that was part of it as well. Getting kind of like a hard time from some insurance companies started to kind of steer me away from that.
Yeah, but you delivered a lot of babies.
I did. I wouldn't say, I probably delivered as many babies in my career as she's going to probably deliver in the first 3 months of her, or 6 months of her residency. So it's a controversial topic because OBGYN obstetrics is part of family practice training. And there's always a discussion. Well, why? Most FPs are not doing it. They're out there. You got to go to places like Idaho and whatever. You'll see them. I just feel like I'm a better doctor because, I feel like sometimes, for example, when there's a medical problem of pregnancy and you have an OBGYN and an internist, they play a little hot potato. The OBGYN says it's an internal medicine problem. The internal medicine doctor says it's an OBGYN problem. No one really wants to take care of it. So I feel like I'm a little more comfortable taking care of medical problems with pregnant patients as a result. So it's just one perspective.
Well-rounded medical education.
Mm-hmm.
Yeah, well, one of the interesting things about Molly is that not only was she were you a biochemistry major?
Oh, I was a genetics major.
Genetics. Yeah. But also you minored in what?
History.
History.
Mm-hmm.
And any particular type of history you were fond of?
Yeah, so I did a concentration in Native American history. Mm-hmm.
Even more interesting. Mm-hmm. So, that's one of the things I think is valuable is that, we are doctors, but we're also people. And I think the idea of having kind of almost more of a liberal arts component to our approach also helps us approach our patient. I was an English major, and I was a pre-med at the same time, but I think it prepared me very well for what I do. Mm-hmm. So I think that's great. Mm-hmm. And I think it's great that your school kind of gave you that variety of very, very specific majors.
So that community has kind of been hard hit this past year, huh?
Mm-hmm. Yeah. Many underserved communities, definitely, especially in terms of like receiving the vaccine, or just being able to get, quality health care during the pandemic has definitely hit the lower socioeconomic communities harder this year for sure.
We have another caller.
Yes, it's a question relayed from the caller. Sometimes they don't want to go on. The aftermath of prostate surgery sometimes requires wearing Depends. Are you familiar with that?
Yeah. So it depends on what type of prostate surgery. The two most common problems are prostate cancer and then BPH, which was benign prostatic hypertrophy, which means the prostate just kind of got big as the time went on, and now the man has urinary problems. So the prostate, it's a pain in the blank. It really has a minor role in male sexual functioning. Other than that, it just causes problems. So if a man has to have his prostate removed for prostate cancer, you're kind of messing around with the muscles that control your urination and can be left with some incontinence problems. Excuse me. Also, if a man had to have everything opened up, because of the large prostate, that's the same thing. Now, that procedure's gotten better. There's something called the green light, which is a laser treatment. It's much less involved than it used to be. And so it's a tough condition, though. And it's a very common complication of any prostate procedure to have some degree of incontinence. Ironic, by the way, because that's usually the one of the symptoms the man was having before was a hard time peeing. I am not sure what to offer by treatment. I mean, there are some meds that can be tried, but my guess is it's an anatomical problem, and all the meds in the world aren't going to, make a difference. Maybe some bladder strengthening, kind of what they would tell a woman with Kegel exercises, might be helpful. If we had a Christine Reinke here, maybe, or a physical therapist, maybe we would ask her. I'm just here tomorrow. I'll ask her.
Very good point, yeah, because it probably has to do with compensating for the fact that now you don't have that prostate there.
Right.
And you're trying to fill it in and make room for a place so that your urination is normal.
There are little muscles on your urethra. That's why a medicine that's commonly prescribed for prostate called tamsulosin relaxes those muscles. So, if you're kind of intervening, you're interfering with the function of those muscles, and therefore, should be left with some dysfunction, some urinary dysfunction. So it's a tough one. We never had a urologist on this show, did we? Mm-mm. Okay, I got to talk to them. Dr. Petro probably would, wouldn't mind coming up. By the way, we do have a guest for next week, Dr. Wahid Faracha. He is a local hematology oncology specialist too, so we're going to probably follow up some of these topics. What else? We didn't really talk about COVID. We filled the morning up, but the answer is to keep it up. Keep getting the vaccine and keep up the vigilance. A little bit of problem in the urgent care setting about getting tests paid for. Unfortunately, that upsets me very much because any roadblock for someone to get testing is potentially is negative. Has a negative effect. In the urgent care setting, the testing will be covered if you have symptoms, but it doesn't really cover you if you don't have symptoms. If you need to test for travel reasons or your employer wants it, or maybe you've just been exposed and so it's very confusing and frustrating. There are still places to get a free test, like at the pharmacies and county facilities, but I don't know, any means necessary, So I was pretty upset by that news of people kind of having to pay a nice amount of money to have the test done.
County-run clinic today at Best Buy. They're giving 2,400 shots today, and I think that they have openings. So go to that Ulster County site. It's COVID ulstercounty.gov, I think.
Right.
And yeah, get signed up because I just had a mental health professional friend of mine who's been volunteering for the county as a mental health volunteer, like for people who are having difficulty or anxiety or, questions about the vaccine, even though they're signed up and they're there and they're waiting in line. People sometimes they have some anxiety or issues. So she's been volunteering doing that. And she let me know that this clinic was going on today at the Best Buy site. Also, just a reminder, if you've signed up at several different sites and then you get your vaccine, make sure that you're canceling with the other sites that you signed up for, because those slots can be filled by other people. And also, just a quick reminder, I had a call last week of a lady who said she needed to get her second vaccine. And I was like, well, you got your first vaccine, so you have an appointment for your second vaccine, because no one is getting a first vaccine without being scheduled for their second vaccine. And it should be on the card that you were given at the appointment. And she insisted that she didn't have a second vaccine scheduled and she didn't have a card. Eventually she did find it. She was scheduled. And also, as a reminder, if you get your first vaccine at one location, that is where you'll receive your second vaccine. So don't show up at the Ulster County Clinic if you got your first shot at the apothecary in Woodstock or down in New York City. You have to go to the location where you got your first vaccine to get your second vaccine. So just quick reminders there.
Well, those are good points. And everyone stay vigilant, I see light at the end of the tunnel, but there's a lot of concerns. Michigan is having a big problem. Still not sure what role these variants are going to have. So we're really not there yet. Concerns about other states being way too open. Remember, we're a country, so if one state is lax, it does affect other states. So anyway, everyone have a good week. Robin, you want to say goodbye?
Molly, thank you so much for being here. It's a pleasure to meet you. Good luck.
You're a really wonderful student.
In all your future endeavors.
Thanks. Yes. We're gonna wait. We have so many things in store for today. We're gonna. All right, and we'll see you next week. Thank you, Dan.
Thank you, Dr. Eric Stamberg, Robin Baker, and a very, very special thanks to Molly Goodman, third-year student at Truro Medical College. And thank you for being with us today at Kingston Community Radio, Medical Mondays. It is Monday, April 12th, and it's 46 degrees right now. This last portion of Kingston Community Radio was brought to you by Ulster Savings Bank, many locations throughout the Mid-Hudson Valley and one near you. Thank you for sharing the morning with us and participating in Kingston Community Radio, AM 920, 92.5 FM, and streaming online at mykcr.org. Talk radio at its best. Inspired discussions of, by, and for the communities. And we invite you to be with us tomorrow morning at 7 a.m. And until then, we wish you every success in growing and developing Kingston and all our neighboring communities. We now return you to Magic 92.5.